The preoperative phase commences when the decision for surgery is made and ends when the patient is transferred to the surgical suite. During this time, the preoperative nurse takes on a multitude of roles, including educator, advocator, and admittance nurse. The nurse's main priority is to complete a preoperative checklist. Each facility's unique checklist ensures that the necessary documentation, admission assessment, physical preparation, and educational needs have been completed prior to the patient entering the surgical suite. Also, look over the different types of surgery on page 284. Informed consent is when a patient autonomously and cognitively grants permission to a provider to perform a surgical procedure after considering all alternatives, benefits, and risks of the procedure. Although obtaining consent is not the role of the nurse, but that of the provider, it is the nurse's responsibility to ensure that the patient has all the information needed to make an informed decision about the procedure being offered. They may also need another consent for anesthesia and also to administer blood products. Some surgeries, if there's more than one component to it, may also need another consent form. For example, my last C-section, I wanted to have a tubal ligation. I had to sign a separate consent form for that. The Patient Self-Determination Act of 1991 grants all patients the right to determine and direct their care in times of medical emergency, which is the right to create an advance directive. An advance directive defines a patient's wishes should he or she be deemed incompetent to express his or her wishes in a medical emergency. Facilities are required by law to provide the means and guidance to complete an advance directive if desired prior to surgery. Within the advance directive, the patient may name a durable medical power of attorney, usually a spouse or adult child, who is designated to make all medical decisions should the patient become incompetent. The advance directive also allows the patient to express desires related to organ donation and end-of-life issues. The role of the surgeon is to obtain consent for the procedure. They are solely responsible for obtaining consent in the presence of the patient and one witness. Many patients admit to not reading the entire consent before signing. The role of the preoperative nurse is to clarify information and ensure patient understanding. Nurses correct common misconceptions and ease concerns of the patient, family members, or support persons. A timeout is a formal process of identification performed by the patient and the healthcare team to identify the correct patient, correct procedure, and correct surgical site. The patient is asked to state his or her full name as printed on the identification bracelet and at least one other identifier, which is typically the patient's date of birth, although there are other acceptable identifiers. The patient is next asked to state the correct site and the procedure he or she is receiving. The surgeon then marks the correct site. Completed patient medical, social, and surgical histories are the key to a successful surgical experience. These questions may be asked during the preoperative workup or upon admission to the surgical facility. As the nurse prepares the patient for surgery, he or she asks a series of detailed questions. Some of the questions may be very personal and at times uncomfortable for the patient to answer. The nurse should remind the patient that this information is important in providing a safe outcome. It is also important to assure the patient that no judgment will be made on his or her responses and that the information will be used only for medical purposes. As the nurse asks questions pertaining to the patient's medical history, he or she should be taking special note of any conditions that will pose a risk during the surgical experience. An example of that could be asthma or COPD or diabetes. A patient's surgical and anesthesia history is a very important part of the patient's history. Previous surgery may have left scar tissue, internal adhesions, or medical implants that need to be considered. The nurse should inquire about types of surgery, the year the surgery was performed, the indication for surgery, any poor incision healing, and what type of anesthesia was used for each procedure. Any negative responses to anesthesia or wound healing must be taken into consideration while planning the patient's care. All patient allergies must be documented to ensure patient safety. Allergies to medications, food, medical dyes, latex, medical adhesive, and environmental conditions must be documented along with the patient's physical response to exposure to these products. An alert bracelet is placed on the patient and the surgical team is made aware. Allergies to antibiotics determine what pre and post operative prophylaxis medications are used. If a patient is allergic to antiseptic solutions such as betadine or chlorhexidine, an alternative skin preparation must be selected. Latex allergies are a serious concern. Each facility must have adequate latex-free equipment available for these cases. In some outpatient settings, patients with latex allergies are scheduled as first cases of the day to ensure that the surgical suite is free of latex contamination. Most hospitals are choosing to create latex-free environments for all surgical suites for this reason. Current medications are an extremely important part of the preoperative history. The use of antihypertensives, anticoagulants, and antiarrhythmics, to name a few, can have a tremendous impact on the care provided in the operating room. Herbal remedies and over-the-counter medications also may have potential interactions with medications used during the procedure and postoperatively, or may increase the risk of bleeding. Look over the meds on table 15.1. Also, question them about any vitamins. There's certain ones that need to be held up to 2 weeks before certain procedures. And I would ask, when was the last time you took blank med? Last oral intake is an essential assessment parameter prior to anesthesia. The guidelines may be modified for different populations, but typically, all patients requiring surgical intervention should have had nothing to eat or drink for at least 8 hours prior to the procedure. A patient who has eaten within 8 hours is at risk of aspiration. The preoperative nurse is responsible for documenting the last oral intake. Patients who have special needs, such as those with diabetes, may have altered NPO orders before surgery. Exceptions are sometimes made that allow patients to take essential medications with sips of water prior to the procedure. According to recent guidelines for elective procedures, the patient may be advised to be NPO 6 to 8 hours for solid foods and 2 hours for clear fluids. Alcohol, smoking, and drug use are sometimes uncomfortable but important questions to ask of all patients. Smoking puts patients at risk for respiratory depression during the procedure and DVT during postoperative care. Because of changes in the pulmonary system, intubation and ventilation may also be compromised. Smoking may also increase the healing time for surgical wounds. Alcohol and drug use may compromise the patient's response to anesthesia. Additionally, postoperative pain management is complicated with recreational drug use, and such use must be taken into consideration when making discharge plans. When a patient history is obtained, some questions require privacy because of their sensitive nature. All psychosocial questions, such as questions about abuse at home and gynecological and mental illness, must be asked when no other family or support persons are present. Any conflicting medical information from the patient's chart and the patient's response should also be addressed at this time. Height and weight help the anesthesia provider determine fluid needs and medication dosages for anesthesia or antibiotics during the procedure. A patient with a high body mass index, or BMI, may also require a larger operating table and recovery bed. Most operating tables have extensions that can meet increased weight requirements. In addition, the OR team may adjust diligence equipment used to transfer the patient. Vital signs are obtained by the nurse during the initial assessment. This includes blood pressure, respirations, pulse, temperature, and pulse oximetry. If available, the nurse should compare the admission vital signs with any previously recorded vital signs to note trends or major changes. In addition to pulse and blood pressure, the nurse further assesses the patient's cardiovascular health, peripheral pulses, color, skin turgor, capillary refill, temperature, and edema are important parameters to assess. The nurse also auscultates the heart for rhythm, rate, and murmurs. The nurse assesses the patient's breathing for rate, depth, rhythm, and adventitious breath sounds such as crackles, bronchi, or wheezing. Pulse oximetry is used to assess the patient's oxygen saturation on room air. In addition, the nurse should report any clubbing in the fingers, which could indicate long-term oxygen deprivation. The nurse must also ensure that the patient has a clear airway. The patient is asked to stick out his or her tongue, breathe with the head tilted up and with the chin down, and swallow. This ensures that an airway and any intubation may be safely maintained during the procedure. The anesthesiologist assesses the patient as well as during his or her consultation. Prior to the induction of anesthesia, it is important for the nurse to obtain baseline neurological evaluation. Assessment of general cognition and the ability to understand commands is important prior to the induction of general anesthesia. The nurse also assesses the movement, strength, and sensation of the extremities. This is especially important in a patient who will receive some type of regional block for the procedure. The presence of postoperative delirium or confusion may delay or postpone the procedure or necessitate admission to the hospital postoperatively. It is important to note potential renal or liver disease in the surgical patient. The effects of anesthesia and/or medications used before, during, and after an operation may be altered if the patient has decreased hepatic or renal clearance. A complete metabolic panel helps the team to identify any signs of dysfunction. A general assessment of the patient includes assessing appearance, such as skin integrity and hygiene. Patients with poor skin turgor or fragile skin may heal more slowly than a healthy individual. Also, the team may want to be careful as to the type of dressings that are used to protect the skin from further damage beyond the incision. For example, in an older patient or a patient with fragile skin, the nurse may want to use a leg strap instead of an adhesive to secure a urinary catheter. If hygiene is an issue, the nurse may need to give extra instruction on wound care in an effort to decrease the risk for infection. It is important for the nurse to note typical bowel habits of the patient, especially if the patient will be admitted to the hospital after surgery. The nurse should also document the presence of normal bowel sounds and any areas of tenderness on the abdomen. The nurse should document any devices noted for urinary elimination, such as an indwelling catheter. The nurse should have the patient void before entering the operating suite and note any unusual odor or color of the urine. The patient may wish to discuss any concerns about urination postoperatively. Some patients worry about being able to get to the bathroom without assistance. The nurse should also document any perineal abnormalities on the chart. Preoperative lab work is essential in determining the patient's readiness for surgery. This can be done at an appointment prior to surgery or the morning of. If done on the day of surgery, labs will be drawn as the nurse places an IV line to be used for venous access during surgery. Typical items that are drawn would be a type and screen or type and cross match, some facilities call it, in case the patient needs a blood transfusion. Complete metabolic panel, coagulation studies, complete blood count, urinalysis, and a pregnancy test. Radiological imaging is sometimes required prior to surgery as well. Common preoperative images are MRI, CT scans, ultrasound, and X-ray imaging. Imaging studies may also be required immediately before and during the surgery to monitor progress. An ECG may also be performed prior to or on admission to the surgical facility, and cardiac monitoring may be ongoing. Patient teaching is an important part of the surgical experience, and a lack of it can affect the postoperative recovery by decreasing activity and mobility, which puts the patient at risk for complications such as DVT, pneumonia, and constipation. Anxiety also plays a role in increasing the risk of infection by decreasing the immune system response. Most facilities have a patient teaching record where teaching is documented. Make sure to include the patient's family, discuss how long a procedure should be, how long the patient should be in PACU, and when family can expect any updates. An IV line is inserted during the preoperative admission, typically for the purpose of the administration of anesthesia and fluids during the surgery. An 18-gauge catheter is preferred because this size is required for the administration of all blood products. Patients receiving abdominal, intestinal, gynecological, or rectal surgery may be asked to perform a bowel preparation. This may be done by use of an enema or gentle laxatives that the patient self-administers at home the night before the procedure. The nurse should confirm and document that this preparation has been performed. Patients scheduled for abdominal, gynecological, or lung procedures may also require the insertion of an indwelling catheter to drain urine. This will keep the bladder empty during a procedure, preventing injury to the bladder. It also allows the surgical team to monitor output in the operating room and PACU. Prior to surgery, skin preparation is done to help prevent infection at the surgical site. Patients may be instructed to shower and wash with betadine or hexachlorophene soap prior to admission. A surgical shave may be necessary depending on the patient's skin type and the location of the incision. If a shave is appropriate, the nurse uses a sterile electric clipper. A razor is not recommended because of the risk of infection caused by small nicks in the skin that may occur with a razor. Preoperative medications may be required. Patients with preoperative anxiety may be prescribed a benzodiazepine, such as midazolam, diazepam, or lorazepam. Antiemetics, such as metoclopramide or ondansetron, may be used preoperatively if a patient has a history of nausea and vomiting due to anesthesia. Preparing the patient for transfer to the OR suite is the final responsibility of the preoperative nurse. Before transport, the nurse should make sure that all consents have been signed, the history and assessment have been completed and documented, including vital signs, learning needs have been met, skin and bowel preparation are complete, and preoperative medication has been administered. The intraoperative nurse may accompany the patient to the surgical suite, or the anesthesia team may be responsible for this transport, depending on the surgical suite's policies. Once transferred, the patient is now considered to be receiving intraoperative care. Initial vital signs provide a base to determine the patient's condition during and after the procedure. Increased or decreased heart rate, increased or decreased blood pressure, increased temperature, and decreased oxygen saturation may necessitate a postponement of the procedure if elective. Evaluation of the physical exam and laboratory values determines readiness for the procedure, indicates necessary adjustments to be made prior to the procedure, and provides a baseline for comparison in the OR and postoperatively. NPO prior to the procedure is essential to guard against aspiration during intubation and extubation due to decreased gag reflexes. Confirm appropriate skin prep and bowel prep have been completed. Prepping the skin with a special soap prior to surgery helps reduce the risk of infection. A bowel prep prior to some abdominal, gynecological, or rectal surgeries is necessary to clear the bowel, which prevents the risk of peritoneal contamination if the bowel is compromised during surgery. Ensure removal of jewelry and prosthetics. An electrocautery unit is used during operative procedures to decrease bleeding. Electricity may travel to any metal on the body, causing a burn. There is also a risk during positioning that the patient's ring may get caught in a piece of equipment, causing injury to the finger. Inform anesthesia and surgical personnel of the presence of any implants. A patient with a pacemaker may need to have the pacemaker disabled. The pacemaker company or a representative of the hospital needs to assume responsibility for this action. Personnel must also be aware of items such as central intravenous lines or Mediports, typically used for long-term medication therapy. Make sure timeouts performed by establishing the right patient, procedure, and site to avoid any operative errors, and then make sure we have a good IV before they're sent anywhere. By telling the patient what to expect in the OR, it'll help control anxiety and increase the patient's comfort. Knowledge of postoperative teachings such as coughing, deep breathing, early ambulation, and leg and ankle exercises significantly reduce the risk of postoperative complications. Inpatient surgical settings perform surgical procedures that require admittance to the hospital unit postoperatively. Inpatient procedures are often very invasive and long. Patients require close monitoring and recovery for more than 24 hours after completion. Ambulatory or outpatient surgery is performed without admittance to a hospital unit before or after the procedure. The surgery center may be freestanding or located in a hospital. It's also known as same-day surgery. Outpatient surgery is often less invasive, shorter in operating time, and requires less than 24 hours of monitored recovery time. Elective surgery is surgery that the patient chooses to have. It is performed for his or her well-being, but is not absolutely necessary. Most elective surgeries are scheduled at the patient's convenience, and many are performed in the outpatient setting. These often include plastic surgeries, oral surgeries, and orthopedic surgeries. Urgent surgery, although necessary, may be scheduled rather than done immediately. Examples of urgent surgeries include hysterectomies, laminectomies, and hip or knee replacements. Sterile team members are those who work within the sterile field and have the responsibility of maintaining asepsis throughout the surgical procedure. The sterile field includes the OR table and the area closely surrounding it, an equipment stand called the Mayo stand that is conveniently positioned close to the patient, and the instrument table. The team members scrub their hands and arms with special disinfecting soap and wear surgical gowns, caps, eyewear, gloves, and sturdy footwear. Sterile team members include the surgeon, surgical assistants, the scrub nurse, or surgical technologist. The surgeon is considered the leader of the surgical team and has the ultimate responsibility for performing the surgery in an effective and safe manner. Depending on the complexity of the surgical procedure, the surgeon may have one or more providers assisting. Surgical assistants are practitioners with specialized training that allows them to assist with surgical procedures. These roles include physician assistants, surgical first assistants, nurse practitioners, and RN first assistants. The scrub nurse, surgical tech, or technician is also known as the scrub. This individual works directly with the surgeon within the sterile field by passing instruments, sponges, and other items needed during the surgical procedure. Before an operation, scrubs help prepare the OR by setting up surgical instruments and equipment, sterile drapes, and sterile solutions. Non-sterile team members perform their duties outside the sterile field, and they include, but are not limited to, the anesthesia provider, circulating RN, unlicensed assistive personnel, and the OR director, coordinator, or manager. The anesthesia provider is responsible for maintaining and sustaining the physiological status of the patient throughout the surgical process. This person may be an anesthesiologist or a certified registered nurse anesthetist. The circulating registered nurse observes the surgical procedure from a broad perspective, assisting the team in creating and maintaining a safe and comfortable environment for the surgical patient. Unlicensed assistive personnel are accountable to and work under the supervision of perioperative RNs. Their duties include patient transport to the OR and helping with the positioning and securing of patients on the operating table in preparation for their procedures. The OR director, coordinator, or manager is responsible for oversight of the business aspect of the OR. This individual is accountable for budgets, staffing, and other areas critical in ensuring the efficient running of the OR. The preoperative assessment is done by the perioperative nurses, typically in the preoperative area, and must accomplish at a minimum 4 goals. Number 1, determine the patient's level of knowledge related to the planned surgery, potential complications, and interventions, such as insertion of an indwelling catheter, and provide education as appropriate. This time also allows the patient to voice specific concerns or questions regarding the procedure. Number 2, confirm that informed consent of the proposed surgical procedure has been obtained. Informed consent discussions are intended to explain the proposed procedure in terms that the patient can understand and is able to articulate. Number 3, determine the patient's level of anxiety in order to support his or her management of preoperative fears and postoperative concerns. This is done by openly discussing the causes of anxiety, such as fear of death or disability, fear of pain, fear of poor prognosis, and fear of rejection if a transplant is the planned procedure. And lastly, number 4, obtain relevant information about the patient. The surgical pause or timeout is done prior to the start of the procedure to verify correct patient, correct procedure, correct surgeon, correct position, correct equipment, and correct imaging studies. The presence of implants such as a pacemaker is confirmed. If antibiotics were indicated, their administration is verified. If the surgical site involves laterality, the correct site is verified and clearly marked with the operating surgeon's initials. The surgical scrub is another key element of patient care in the OR that is done to prevent surgical site infections. Although the human hand represents a vital tool in the care of a patient, it also may act as a portal and transmitter of infection. The warm, moist conditions inside surgical gloves are an ideal environment for the rapid growth of microorganisms. To minimize the risk of infection to the patient, it is essential that OR personnel who will be directly involved in invasive surgical procedures follow appropriate hand hygiene and hand scrub procedures. A systematic approach to this procedure is an efficient way to ensure proper technique is completed. The traditional surgical scrub starts with washing the hands thoroughly. This is followed by washing with a disposable scrub sponge from a clean area, such as the hand, to a less clean area, the arm. Scrubbing with a long-acting, powerful antimicrobial sponge for at least 3 to 5 minutes allows adequate time to remove, inhibit, or kill as many microorganisms as possible and protect against infection if gloves develop holes, tears, or nicks during the operative procedure. An alternative hand rub using a waterless alcohol-based preparation may be used, especially if surgical staff members are allergic to available antiseptic scrub solutions. Prior to performing the scrub, all jewelry must be removed, nails should be clean and short, and gel or acrylic nails are not allowed. Wearing of appropriate surgical attire is another important step in reducing the risk of postoperative infections. There are several levels of surgical attire. The first level is worn by everyone working in the OR. This apparel is popularly referred to as scrubs because it is usually worn in a scrubbed or sterile environment. Scrubs are the shirts and pants or dresses worn as uniforms by surgeons, nurses, and other support staff in the OR. The next level of attire, which is typically referred to as surgical attire, consists of the sterile gown and gloves worn by staff working directly within the sterile field. This attire includes gloves, caps, masks, gowns, protective eyewear, and sturdy footwear. General anesthesia is what the layperson calls being put to sleep. Under general anesthesia, a patient is in a reversible unconscious state. General anesthesia provides all of the goals of anesthesia, including manipulation of physiological systems and functions. It is achieved using a variety of methodologies, either alone or together. These include inhalation of volatile agents such as gases, IV agents, and muscle relaxants. The patient receiving a general anesthetic that includes the administration of a muscle relaxant requires ventilatory support in the form of an endotracheal tube or ETT tube. Look over tables 16.2 and 16.3, please. Not to scare you or anything, but I'll tell you a quick little story about my father-in-law who was not officially diagnosed with dementia, but definitely has all signs pointing towards it. He decided to have a rotator cuff surgery redone on his right shoulder last year. And this man was someone who was outside all day long, from sunrise to sundown, loved working in his workshop, could drive where he wanted to go. He didn't forget most things, it wasn't that bad. And like I said, he didn't have an official diagnosis. He goes to have the surgery, and the anesthesia set off his dementia. So now he's been bedbound since March of last year when he had that rotator cuff repair done. So like I said, I don't want to scare you. I'm just letting you know that that is a potential complication. However, your teacher here is a pro at having surgeries. I've had 3 C-sections, a hysterectomy, an L5S1 discectomy, carpal tunnel surgery on the right hand. I had my wisdom teeth removed with IV sedation. So that was, and they had to break one of my teeth to remove it to get it out because my roots to my teeth were around a vessel. So they had to be careful with that. I think that's all my surgeries. I've had plenty of them. So you just never know what's going to happen. But just things that we need to be aware of. That's why it's important to do your assessments ahead of time. Malignant hyperthermia is a hypermetabolic state that can be caused by exposure to a triggering agent. The triggering agent causes sustained muscular contractions related to an increase in intracellular calcium ion concentration. The sustained contractions result in signs of hypermetabolism. These include acidosis, tachycardia, hypercarbia, glycolysis, hypoxemia, and hyperthermia. The reaction usually begins to occur soon after the exposure, but it has been known to be delayed until the patient is in the recovery area. The most specific sign of malignant hyperthermia is skeletal muscle rigidity. However, the first sign noted by the anesthesia or nursing staff is an unexplained tachycardia. For the anesthesia provider, hypercarbia is the most sensitive indicator of potential MH. Myoglobinuria is another early sign. The patient's urine turns from dark amber to brown. Hyperthermia, the classic sign of malignant hyperthermia, is usually a late sign. It's treated with administration of dantrolene, which is a muscle relaxant, and cooling the patient with either ice bags, cold normal saline IV infusion, cold nasogastric lavage, or a combination of them. Regional anesthesia is a local anesthetic used to block or anesthetize a nerve or nerve fibers. Types of regional anesthesia or blocks include spinal, epidural, caudal, and nerve blocks. Spinal medication is injected into the spinal canal or intrathecal space surrounding the spinal cord, typically in the lower back or lumbar region. The injection lasts for several hours. It may also be given as a continuous spinal anesthesia via a catheter. It is important to keep the head of the patient's bed flat after spinal anesthesia to avoid a headache. An example of a surgery where a spinal medication is done or a spinal anesthesia is done would be a C-section. Epidural medication is injected into the epidural space into the lumbar region or thoracic region. A catheter is inserted for periodic or continuous injection. Spinal headache is avoided because the intrathecal space is not entered. An example for this one would be a woman in labor delivering vaginally. Caudal is a form of epidural anesthetic where the medication is injected into the epidural space through the caudal canal in the sacrum. And finally, a nerve block, anesthetizing of a nerve in an extremity, is done to allow surgery in a specific area. One I can think of offhand would be they block the phrenic nerve when they do a rotator cuff surgery. Local anesthetics cause a reversible conduction blockade of nerve impulses when they are placed in proximity to nerve membranes. The anesthetic diffuses into the nerve and inhibits the propagation of signals for pain and muscle contractions. Pain fibers are affected first, then sensory fibers and motor fibers. High concentrations inhibit all qualities of sensation as well as muscle control. Low concentrations selectively inhibit pain sensation with minimal effect on muscle power. Adverse reactions are due to overdosage, rapid absorption, and hypersensitivity. Reactions vary from mild, such as hives, itching, and rash, to severe, which would be acute anaphylactic reaction. Examples include amides and esters, which are defined by their chemical composition. Monitored anesthesia care, or MAC, provides anesthesia without unconsciousness. The patient has a decreased level of consciousness but maintains a patent airway and responds appropriately to verbal commands and physical stimulation. MAC couples sedation and analgesia with local anesthetics. The usual medications utilized are benzodiazepines such as diazepam and midazolam, and narcotics such as fentanyl and meperidine. During the administration of both local anesthesia and MAC, signs are posted outside the OR alerting staff that the patient is awake. It is important that OR staff are mindful of conversations in the room and keep them to the minimum needed to communicate needs or to comfort the patient. Airway management is the process of protecting and ensuring adequate oxygenation and ventilation during an operative procedure. This is not only an essential component of care for patients receiving general anesthesia, but also an important consideration with any kind of anesthesia that can potentially compromise the airway. Airway compromise can be caused by relaxation of the soft tissues of the oropharynx. This relaxed effect may create an occlusion of the trachea or trigger a laryngospasm, where the larynx constricts and cannot easily be re-expanded. The airway may also be compromised in patients who present with anatomical abnormalities such as a small mouth, short neck, inability to open the mouth fully, obesity, or facial or cervical injuries. There are four standard positions commonly used for surgical procedures. These positions are often identified according to the surgeon's preferences and surgical approaches and the patient's physiological requirements. They are supine, prone, lateral, and lithotomy. Supine is the most frequently used patient position and is the most natural position for the body at rest. This position is used for procedures on the anterior surface of the body, including abdominal, abdominothoracic, vascular, orthopedic, head, neck, and ophthalmic operations. The patient is placed on his or her back with the legs extended and uncrossed, and the arms on arm boards or at the sides with the palms down. Proper arm placement with extension at less than 90-degree angle is necessary to avoid brachial plexus stretching and compression. The arms must not be positioned lower than the spinal column, and the spinal column should be in a straight line with the legs parallel to the OR bed. The patient's head is in line with the spine, and the face is upward. The hips are parallel with the spine. In prone, the patient is placed face down, resting on his or her abdomen and chest. Chest rolls under the clavicles till the iliac crest raise the weight of the body from the abdomen and thorax. The arms may be supported along the sides of the body. The head is turned to one side, resting on a pad donut to prevent pressure on the ears, eyes, and face. Female breasts should be moved laterally to reduce pressure on them, and male genitalia must be positioned to be free from pressure. In the lateral position, it's used primarily for thoracic, renal, and orthopedic hip procedures. The patient is placed in the supine position for anesthetizing and then turned to the unaffected side. Lastly, lithotomy. The patient is in the supine position with the legs raised and abducted to expose the perineal region. The legs and feet are placed in stirrups that support the lower extremities. The lithotomy position is used for vaginal, obstetrical, urological, and rectal procedures, and for radical resections of the groin, the vulva, and the rectal areas. The choice of a particular positioning device for a surgical procedure depends on many variables. Patient variables such as height, weight, age, and physiological condition, and the position required for the procedure influence which devices are used. The surgeon's preference affects the selection of a positioning device as well. Routine positioning devices used for most surgical procedures include but are not limited to the following: OR bed, headrest, arm boards, arm restraints, padding for bony prominences, blankets, pillows, safety straps, sandbags, bean bags, towels and sheets, foam pads, and gel-type devices. Risk factors for pressure injury would be long surgical procedures, vascular surgery where perfusion is already compromised, demineralizing bone conditions, and excessive sustained pressure on body parts. Ensure OR consent has been signed. Signed consent indicates the patient has had all risks, benefits, and alternatives to the procedure explained and is required before surgery can begin. Ensure the patient is correctly positioned and the appropriate patient positioning devices are used. Avoid unnecessary pressure points, thus skin breakdown or injury. Monitor staff in the use of a proper scrub and donning of OR attire, and validate that OR room and equipment have been thoroughly cleaned. Maintain sterility in the OR to prevent infection. Ensure readiness of the OR suite. Check that all necessary equipment and supplies are available. Ensure irrigation fluid and instruments are at the appropriate temperature. And confirm flashed instruments are cool. Perform timeout. The timeout is a safety factor essential for preventing preventable errors. Perform equipment safety check. Properly functioning equipment can prevent patient injury. Utilize sterile technique while inserting a Foley catheter and setting up the sterile field. Proper sterile technique prevents patient infection. Assist the anesthesia care provider during intubation by applying cricoid pressure as indicated. Properly ground the patient as indicated. Proper grounding can prevent the patient from electrical injury and burns. Keep the patient safety belt in place while the patient is on the OR bed. Patient falls can be avoided through the proper use of a safety belt and side rails. Apply support hose and sequential compression devices as indicated. DVT can be prevented by the use of support hose and SCDs. Keep the patient warm with blankets and use warm irrigation to prevent hyperthermia. Maintain a sterile field to prevent infection. Accurately record the number of sponges and sharps used on the count board to prevent retained foreign bodies. Accurately measure irrigation fluids and communicate the amount to the anesthesia care providers to avoid a fluid deficit. Keep OR doors closed during the procedure to maintain sterility and prevent infection. Keep hallways clear of extra equipment. An unobstructed pathway is necessary to ensure quick access to the patient in an emergency. Explain to the patient your actions and what to expect when entering the OR. Decrease and manage the patient's fear of the operative experience. Keep the family updated during the procedure to decrease and manage family's fear of the operative experience. Postoperative period begins immediately after surgery and continues until the first follow-up postoperative provider visit. During this time, it is vital that the patient be closely monitored to ensure recovery and avoid serious complications that may occur related to the surgical experience. Postoperative care is delivered on a continuum. It begins in the post-anesthesia care unit immediately after surgery and continues either in a hospital setting or at home. The focus of this chapter is the specialized care delivered in the post-anesthesia care unit and important nursing assessments and interventions delivered on the general inpatient surgical unit. The post-anesthesia care unit is a special critical care unit where patients are transferred immediately following sedation or anesthesia for surgical, diagnostic, or therapeutic procedures. Because of anesthesia, there's a temporary decrease in or loss of consciousness and loss of motor and reflexive control of respiration. The transition from anesthesia to recovery carries risks for potentially life-threatening complications, as well as discomforts such as nausea and vomiting and pain. During this transition, patients need assistance to maintain a safe internal physiological balance. The goal of care in the PACU is to safely allow the patient who has had anesthesia or sedation to awaken and resume normal bodily functions while controlling or minimizing pain and preventing complications of surgery and anesthesia. Phase 1 involves the nursing care provided in the immediate post-anesthesia period. This phase is generally in the PACU or intensive care unit. There is intensive, close monitoring of all vital signs with continuous electrocardiogram monitoring. There is a focus on cardiac, respiratory, and neurological functions, surgical site monitoring, and pain and temperature control. The goals of care in this phase are to stabilize the patient's vital signs, allow the patient to awaken from anesthesia, and achieve adequate pain control. In phase 2, the monitoring is less intensive because the patient has met the criteria, allowing transfer from phase 1. The focus of nursing care is on preparing the patient to be discharged to an extended care environment or home. In phase 3, or extended observation of post-anesthesia care, focuses on providing ongoing care for those patients remaining in the postoperative care area after discharge criteria have been met. A delay in discharge home when anticipated after a same-day surgery is most often caused by uncontrolled postoperative nausea and vomiting or pain, delays in the surgery schedule and OR availability, and social factors such as a responsible adult not being present to take the patient home. The goal is to prepare the patient for transfer to an inpatient unit when a transfer bed is made ready or self-care and discharge home. Inpatient PACU is typically one big room, but recent PACUs are being designed with individual rooms for patient privacy. Patients are managed by anesthesia and nursing staff. Inpatient PACUs care for patients recovering from major or minor surgical procedures on a continuum from low to high risk of complications. Intensive care units. Postoperative care in the ICU is indicated for critically ill patients who require extensive and complex monitoring because of the high risk of complications. These patients are transferred directly to the ICU immediately following the operative procedure. They are managed by the ICU team and nursing staff. Outpatient PACU. Outpatient post-anesthesia care is provided for patients going home after the procedure. The post-anesthesia care is delivered in the same outpatient setting where the procedure is performed. These settings include an outpatient area in the hospital setting, freestanding ambulatory surgery centers, providers' offices, urgent care centers, and rural health clinics. Patients undergoing procedures in a procedure area, such as endoscopy or cardiovascular interventional laboratories, require post-operative monitoring and care in the procedural area if IV sedation or anesthesia is required for the procedure before return to the inpatient setting or being discharged home. Patients are all individuals and react differently to the different types of medications, treatments, surgery, procedures, or anesthesia. Therefore, postoperative nursing management should be individualized and should include assessment and monitoring of the patient's response to surgery and anesthesia, timely interventions to resolve the problems, concerns, and needs of patients, evaluation of these interventions, including effects or adverse effects of medications, reassessment of patient condition, and evaluation of achievement of discharge criteria. On admission to the PACU, the patient is simultaneously connected to cardiac and other monitoring devices while an immediate assessment is performed. Critical areas of assessment on admission to the PACU include the following: airway patency, respiratory status including oxygen saturation and capnography if indicated, and auscultation of lung sounds. Vital signs: blood pressure, pulse, apical and peripheral, cardiac monitor rhythm, hemodynamic pressure readings if indicated, temperature. Neurologic function including level of consciousness, motor function and sensation, temperature and color of skin. Pain level and comfort level. Condition of dressings, assessing for bleeding or drainage. Condition of visible incisions. Presence and patency of IV catheters, drains, and other catheters, and hydration status and fluid therapy. Laboratory tests done postoperatively assess for bleeding, fluid loss, electrolyte imbalance, renal function, and clotting abnormalities. A chest radiograph is done postoperatively if any complications from surgery due to central line placement, intubation, or anesthesia are suspected. An EKG is always done as a preoperative assessment. It is ordered postoperatively if any EKG changes were identified during surgery or after. The best results in postoperative pain management involve multimodal pharmacological therapy or synchronous administration of NSAIDs, acetaminophen, opioids, and local anesthetics. In addition to pain medication, studies demonstrate that a variety of non-pharmacological methods decrease pain and the need for medication postoperatively, such as music therapy, massage, prayer, and meditation. However, few PACUs offer these options to all patients as part of their pain management programs. Most postoperative patients are given a patient-controlled analgesia pump or a PCA pump for delivery of opioid medications. A PCA pump is an infusion of a prescribed amount of analgesia through an IV route when the patient pushes a button. Complications include dehydration, electrolyte imbalance, wound dehiscence, aspiration, increased length of stay, decreased ability to perform ADLs, ED visits, and readmission. Risk factors include young, non-smoking females, history of motion sickness, general anesthesia, and high doses of the medication neostigmine. Treatment: we want to minimize postoperative opioids, evaluate pharmacologic interventions, multimodal pain management strategies, and prophylactic antiemetics. Immediately following surgery and anesthesia, all patients are at risk for respiratory depression from anesthesia and pain medication, and bleeding from the surgical procedure itself, requiring careful and frequent nursing assessment. For the neurological system, we want to check the level of consciousness and their motor ability and sensation. Anesthesia produces a decreased level of consciousness or a reversible loss of consciousness. A continued decrease in level of consciousness, restlessness, agitation, and confusion may indicate inadequate reversal of anesthesia or complications of anesthesia, or could be a result of hypoxia. Motor and sensation abilities must also be monitored to assess for the reversal of any nerve blocks administered during surgery for patient safety. Any deviation from the normal range of values for blood pressure, heart rate, oxygen saturation, respiratory rate, or temperature could indicate a postoperative complication. Peripheral pulses, skin temperature, and skin color should be assessed because weak peripheral pulses, cool skin temperature, and/or pale skin color could signify inadequate perfusion resulting from blood loss and decreased cardiac output. Decreased urine output less than 30 mL per hour may indicate dehydration due to fluid or blood loss or urinary retention. Pain is an expected outcome of a surgical procedure, but should be managed appropriately. Regular assessment of pain is necessary for the evaluation of pain management. Uncontrolled pain may be an indication of a complication. Extended time in intraoperative positioning may cause excessive pressure and skin breakdown. Excessive blood or drainage on wound dressings may indicate inadequate wound closure or bleeding and requires follow-up by the provider. Connect to continuous cardiac monitor immediately upon admission to the PACU. Any changes in vital signs or dysrhythmias may indicate complications associated with anesthesia or the operative procedure. Start admission assessment immediately upon admission to the PACU because it is essential to get a baseline to understand the patient's presenting status. Vital signs are often documented every 15 minutes to allow prompt response to changes as necessary. You should participate in handoff from the OR. Good communication is essential for a smooth transition of care between the OR and PACU to ensure the patient's needs are met and complications are avoided as much as possible. The initial PACU assessment is compared with the preoperative assessment. The assessment is monitored continuously to track the patient's recovery or to identify any problems. Medicate the patient as ordered for pain and nausea. Nausea centers may be triggered by anesthesia, and pain is a result of tissue trauma from surgery. Hand off to inpatient unit if necessary, and you can read more about that in box 17.3. A clear, concise handoff to the inpatient unit is essential for safe patient care. Inform the family when the patient arrives to the PACU and make contact every hour. Communicate the plan of care. Allow visiting per hospital guidelines. If being discharged, provide discharge instructions with family present. Communicating and maintaining contact with a family member as well as allowing visitation is essential to help relieve anxiety and stress. Because of the effects of anesthesia, the patient may not remember discharge instruction, so it's essential to have the family member or someone else present. After receiving the handoff from the PACU nurse, the inpatient nurse must review the new orders written by the provider on the postoperative inpatient unit to prepare to care for the patient in this new setting. Orders will contain information about vital sign parameters, activity and diet, medications for postoperative pain, nausea, and vomiting, thromboembolism prophylaxis, postoperative imaging and laboratory studies, any special precautions related to the surgery, and the continuation of the patient's routine preoperative medications. The nurse and staff of the inpatient unit can then begin setting up the room with the supplies necessary to support the patient. Once the patient has arrived, taking vital signs and completing a thorough assessment should begin immediately to establish a baseline. This baseline can be compared to pre-surgical status and can be used to evaluate the patient's post-operative progress. Some potential complications in the respiratory system include atelectasis, pneumonia, and pulmonary embolus, all potentially resulting in inadequate gas exchange, hypoxemia, and hypoxia. All are related to hypoventilation, venous stasis, and an ineffective cough secondary to immobility and pain. Immobility can cause an accumulation of mucus in the lungs, resulting in atelectasis and pneumonia. Immobility can also result in venous stasis and clot formation or deep vein thrombosis formation, which can ultimately result in a pulmonary embolism. Pain can cause hypoventilation, which results in poor gas exchange and a weakened cough, further compromising the removal of secretions and oxygenation. Please look over Table 17.2. The body's natural stress response to the surgical procedure may result in fluid and electrolyte complications. Acute stress and surgical fluid losses lead to a sympathetic response of tachycardia and vasoconstriction. There is increased secretion of adrenocorticotropic hormone, or ACTH, stimulating the adrenals to release cortisol, hydrocortisone, and aldosterone. The pituitary is stimulated to release antidiuretic hormone, ADH, and the renin-angiotensin-aldosterone system, RAAS, is stimulated. All result in fluid retention, sodium retention, and urinary loss of potassium. This may result in fluid overload and hypokalemia. Hypokalemia affects cardiac contractility and may lead to lethal dysrhythmias. Conversely, fluid losses secondary to untreated or poorly treated preoperative dehydration, surgical fluid losses, bleeding, wound drainage, and/or vomiting may result in decreased cardiac output and poor tissue perfusion. Additionally, clot formation or venous thromboembolism, typically in the lower extremities, is a risk due to patient immobility or patient positioning in the OR. There are several severe neurological complications related to surgery, and more specifically anesthesia. Delirium, defined as inattention and disorganized thinking, is a common complication affecting up to 70% of patients over 60 years of age. It is associated with persistent cognitive decline, prolonged ICU and hospital length of stay, and increased mortality. Treatment is mostly based on recognition of populations at risk and prevention. Preventive measures include decreasing the irritation of invasive lines, tubes, and drains that increase agitation as quickly as possible. Antipsychotic medications such as low-dose haloperidol or Haldol may be used as a treatment, along with reorientation and reassurance. Another complication common in the older patient is postoperative cognitive decline, or POCD, which can be subtle and temporary or may last for weeks or months, causing delays in return to normal functioning such as work. Postoperative ileus, or POI, a slowing of gastric and bowel mobility, is a complication largely associated with gastrointestinal surgery when there is manipulation of the bowel. It can also occur with other procedures due to anesthesia, immobility, opioid pain medication, and previous abdominal surgery. Patients present with nausea and abdominal pain. Interventions include insertion of a nasogastric tube to decompress the stomach to ease nausea and prevent vomiting and aspiration. Patients are kept nothing by mouth, or NPO, until bowel motility returns. Urinary retention can occur due to complications from anesthesia, opioids, and immobility. Anesthesia depresses the nervous system, which can affect the nervous system's control of micturition. This can result in a decreased sensation of a full bladder and urinary retention. Opioids may interfere with the patient's ability to fully empty the bladder. Immobility and bed rest impact the ability to fully relax the perineal structures to allow voiding and complete emptying of the bladder. Surgical procedure typically involves an incision through the skin and tissues, disrupting the first barrier to infection, the skin. Surgical site infection is a risk in the perioperative period, more commonly seen in older, immunosuppressed, or malnourished patients and those with longer hospital lengths of stay. The surgical site will appear warm, red, and edematous, with purulent drainage, and the patient will complain of increased pain, the cardinal signs of inflammation. In the worst case scenario, the wound may dehisce, the sutures or staples fail, and the wound opens up. The wound must be cleaned and drained. Sterile saline dressings must be maintained until the wound is healthy enough to be reapproximated or resutured. Adequate nutrition is imperative for wound healing. Low oxygen saturation and/or increased respiratory rate and work of breathing could signify a pulmonary embolism, or PE, atelectasis, aspiration, or pneumonia. Adventitious lung sounds, such as rhonchi or diminished or absent sounds, could also reveal atelectasis, aspiration, or pneumonia. Rales may indicate fluid overload. Blood pressure, heart rate, and temperature monitor for trends and values. Deviations from normal could signify complications. The most common postoperative complication is hypotension and tachycardia due to blood or fluid loss. Hypertension and tachycardia may occur due to the stress response to surgery and pain. Increases in temperature may indicate infection due to pulmonary issues or surgical site infection. Cool, pale skin with weak pulses and delayed capillary refill may indicate decreased volume and cardiac output. Decreases in level of consciousness, confusion, agitation, or disorientation may indicate the onset of delirium or POCD. It may also be due to excessive pain medication or respiratory dysfunction. Irregularities in pupillary size and reaction or Glasgow Coma Scale score may be due to increased intracranial pressure. Assess bowel sounds, flatus, and bowel movements because they reflect the return of GI motility. Postoperative nausea and vomiting may be associated with anesthesia. Absent or hypoactive bowel sounds, nausea, and vomiting may indicate paralytic ileus. Increased urine output in the initial postoperative period may be due to excessive IV fluids given intraoperatively. Decreased urination can result from dehydration or the release of antidiuretic hormone and the initiation of the RAAS due to stress and surgical fluid losses. Monitor for urinary retention that may be caused by complications from anesthesia, opioids, and immobility. Cloudy urine, tea or cola-colored urine, and urine with a foul odor are signs of urinary tract infection. Assess surgical incisions and dressings for proximity of closed edges, presence and quality of drainage, and intactness of surrounding skin. Red, warm, edematous tissue with purulent drainage, along with complaints of increased pain, indicates infection. Assess for the presence and staging of any skin breakdown or pressure injuries that may be associated with prolonged positioning in the OR or immobility postoperatively. With drains, assess for excess bloody or cloudy drainage. Excessive or bloody drainage may indicate surgical site bleeding. Cloudy drainage may indicate infection, and absent drainage may indicate a clogged drain. Pain should be monitored and treated. Poorly controlled pain may indicate surgical complications or the need for alternate pain control treatment. Fluid and electrolyte balance, monitoring of glucose levels. Fluid retention may occur due to activation of the RAAS and release of ADH in response to stress and dehydration. Hypokalemia, a risk factor for lethal dysrhythmias, and hypernatremias may occur with the activation of the RAAS. Hyperglycemia may occur related to the stress of the surgical experience and is a risk factor for infection because high blood glucose fuels bacterial growth. Encourage the patient to cough and deep breathe to facilitate full lung expansion and airway clearance. Maintain IV fluids as ordered to maintain intravascular volume. Start PO fluids as ordered with the return of bowel sounds. Maintain as tolerated with no complaints of nausea. Change position frequently. Encourage ambulation as soon as possible. Mobility encourages lung expansion. Requires muscle use to prevent atrophy. Aids in DVT prevention. Helps relieve constipation. Aids in pain and fatigue relief. Improves mood. Reduces anxiety. Increases comfort. instills a greater quality of life and independence, and is a factor in decreased length of stay. DVTs, when they occur, commonly occur in the posterior calf with noticeable redness, swelling, heat, and pain. A combination of administering anticoagulants as ordered, encouraging activity, and using compression devices is the most effective means of prevention. Provide diet as ordered. Nutrition is essential for healing. The progression and type of diet are unique to each type of surgical procedure, but in general, PO fluids and diet are started when bowel sounds return and are maintained as tolerated by the patient. Change dressing as ordered, utilizing proper hand hygiene before and after care, and correct use of clean and sterile gloves to prevent surgical site infections. Provide complete documentation of wound assessment and care. Prolonged pressure deprives tissues of oxygen and nutrients, causing ulceration. Pressure injuries are most often found over bony prominences. To prevent pressure injury development, patients should be encouraged to mobilize and adjust their position frequently. Those who are not able to do so should be assisted to turn and reposition every 2 hours. Encourage proper nutrition to promote skin integrity and wound healing. Encourage patients to call for assistance. Most falls happen when patients are trying to do something unassisted and/or without supervision, such as transferring from the chair to the bed or ambulating to the bathroom. Use bed alarms as necessary. Preoperative falls put patients at higher risk for postoperative falls. Administer stool softeners and laxatives as ordered. Constipation in the postoperative patient is a common occurrence due to the effects of anesthesia or other medicines, particularly opioids, immobility, or improper hydration. Encourage the patient to ambulate, drink plenty of fluids, and eat a nutritious diet high in fiber. Medications other than or in conjunction with opioids to treat pain should be explored. Stool softeners add water into the bowel. Laxatives improve bowel motility to aid in defecation. Removal of the indwelling Foley catheter helps prevent catheter-associated urinary tract infections and reduces the risk of falls by removing a tripping hazard. Educate the patient on unit routines, such as the frequency of vital signs, assessment, visitation hours, and staff members on a unit, and orient the patient to his or her room, how the call bell works, and how to order food. Safety topics include standard or isolation precautions, patient identification methods, fall precautions, activity or diet restrictions, and bleeding risk precautions. Discharge education is essential to ensure that the patient safely transitions to home and avoids readmission to the hospital. Teaching should be done in the presence of a family member or significant other who will help the patient upon returning home.